Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for Clinical Clips in Hemophilia, Cutting Edge Advances, presented at ASH 2024. My name is Dr. Guy Young, and I'm a professor of pediatrics at the University of Southern California Keck School of Medicine and director of the Hemostasis and Thrombosis Center at the Children's Hospital, Los Angeles. In this clinical clip, I'll highlight key data presented at the 66th American Society of Hematology Annual Meeting and Exposition in San Diego, California. We're first going to talk about two abstracts related to factor products. And the first one, and they're both actually related to efanesoctocog alpha. The first one was an oral abstract presented by Dr. Robert Klamroth, and it's titled Clinical Outcomes Over 3 Years of Once-Weekly Efanesoctocog Alpha Treatment in Adults and Adolescents with Severe Hemophilia A, Second Interim Analysis from the Phase 3 Extended Long-Term Extension Study. Basically, this was the study that continued from the Phase 3 trial of efanesoctocog alpha that is now published by Aneta Wądrzygalski in the New England Journal of Medicine. This trial has taken the patients out beyond the first year and well into, past the second year into the early third year. The weeks of follow-up total was 116 weeks. What this study showed in terms of the extension study is that patients continued to not have frequent bleeding events, not in their joints, not treated bleeds. The ABRs were all continued to be less than 1, as was seen in the main phase of the study. In terms of safety, there were no inhibitors that developed in any of the patients in the long-term extension study. And furthermore, there were no other adverse events that were considered to be related to the efanesoctocog alpha treatment directly either. So essentially, this provides us with additional evidence that efanesoctocog alpha is a very effective and safe treatment for adults and adolescents with severe hemophilia A. I say adults and adolescents because this was the trial that continued the extension part for adults and adolescents. There's a pediatric trial as well, but this did not cover the pediatric extension study. The second abstract on efanesoctocog alpha was presented by Christoph Koenigs, also from Germany. He took a look at an association, or the abstract called Association Between Hemophilia Joint Health Score and Quality of Life using results from the Extend 1 efanesoctocog alpha phase 3 trial. So he was looking only at the phase 3 portion, the main phase, not the extension phase. But what he evaluated was what is the relationship between joint health, the hemophilia joint health score, and quality of life instruments. And essentially what was found here is that for patients who reported an improvement in their hemophilia joint health score over the course of the study, they also simultaneously demonstrated improvement in a variety of quality of life instruments, obviously specifically related to physical health domain, but also to other domains as well. So the point here is that for those patients whose joint health improved by this specific score, the HJHS, also had improvement in quality of life instruments. The patients who did not have an improvement in their HJHS basically did not have improvements in their quality of life. It wasn't as if things necessarily deteriorated. There were 1 or 2 domains that seemed to get worse, but nothing really significant of note. So this basically just links the fact that if you're on efanesoctocog alpha and you've got improvement in joint health, you're going to reflect that as well in the improvement in quality of life. For those whose joint health didn't improve, it was probably already because their joint score was so low. And so for them, their quality of life, some of them stated they got worse, some got better, but that probably had more to do with either social reasons or other things unrelated to the study. So the second abstracts that we're going to take a look at are going to be related to non-factor therapies. And specifically, we're going to start with factor VIII mimetics. There was a presentation by Professor Tadashi Matsushita, which was titled Safety and Efficacy of Mimate, prophylaxis administered once every 2 weeks for patients with hemophilia A, with or without inhibitors, interim analysis of the Frontier 4 open label extension study. So Mimate is a next generation, if you will, or second generation, or second to market, however you like to think about it, bispecific antibody. So essentially, it is similar to emicizumab with some biochemical changes. It is now being studied in phase 3 trials. Those trials are called the Frontier trials. The Frontier 2 trial was the phase 3 trial, which read out 6 months ago at the International Society on Thrombosis and Hemostasis meeting, and those results have been previously presented. What this abstract looked at is patients who went on to Frontier 4. This is the global extension study, so all the patients on the Frontier studies, all the various different studies, from the phase 1 to the phase 3 to the pediatric study, et cetera, will eventually all fall into this study called Frontier 4. What we're looking at here is only patients who are on the phase 1 trial. Once they completed the phase 1 trial, they all moved into Frontier 4 and were required to dose every 2 weeks. This was to gain knowledge on the every 2-week dosing, because the phase 3 trial had weekly or monthly dosing. So it just gives us an opportunity to understand what every 2-week dosing looks like. So that's what this trial was all about. These patients were followed for about a year and had low bleed rates, similar to what was seen in Frontier 2. So in other words, bleed rates were around, if I remember, 1.5 or so as far as the ABR is concerned. And there were no safety concerns related specifically to the medication, other than injection site reactions, which were fairly minimal, and no patient discontinued the drug because of that. So this study of Mimate just provides further evidence for the use of every 2-week dosing specifically, and just further evidence to support its use as an effective prophylactic agent for both prevention of bleeding and also demonstrated safety as well. So the second study on a factor VIII mimetic we're going to look at is actually on emicizumab, the one that's been around for a long time. It was presented by Conrad van der Zwet, and it's titled Pharmacokinetic Guided Reduction of Emicizumab in Patients with Congenital Hemophilia A in the Netherlands, interim analysis of the DOSE-EMI study. So emicizumab has been around and licensed for 6 to 7 years around different countries in the world for use in patients with hemophilia A to prevent bleeding, patients of all ages, and patients with and without inhibitors. There's been questions about whether the dose of emicizumab, that is the approved dose all around the world, is really necessary to give that much. I guess that's kind of the question. Can we lower the dose? We know from studies in developing nations, lower middle income countries, that patients have reduced, or prescribers have reduced, the doses of factor VIII compared to what we use in better resource countries, and finding quite effective results. And so the question here is, for a drug as expensive as emicizumab, can we lower the dose without lowering any of the efficacy? The short answer is yes. So they had a dose strategy where patients would be targeted towards a lower pharmacokinetic level of emicizumab. So instead of 50 micrograms per milliliter as the trough, they were aiming for more around 30 micrograms per milliliter. And they had done some simulation type studies that suggested that that dose, or that targeted level, should be just as effective as the higher one. So they put patients into these two pools, maintaining the regular dose, or actually the targeted lower dose. And essentially what they found was that there was no difference in bleeding rates when you use the targeted lower dose. And so as a result, they suggested that it would be much more cost effective, particularly around the world, in some countries where emicizumab is financially restricted to either certain patient populations or just limited to how many patients can get it, that by lowering the targeted level of emicizumab, it will utilize a lower dose, lower the cost, and allow for better access to patients around the world. So this is a well thought out, well planned study and executed well with really good results. So now we're going to jump to a couple of other abstracts on non-factor therapies. And we're going to first talk about concizumab. So the first abstract will be one by Amy Shapiro. It's called Annualized Bleeding Rates in Patients with Hemophilia A or B and Inhibitors with and without target joints at baseline. Results from the concizumab phase 3 Explorer-7 study. So Explorer-7, Explorer is the name for the series of trials on concizumab. Explorer-7 is specifically for patients with hemophilia A and B with inhibitors. The study, the full phase 3 study, has already been published by Tadashi Matsushita in the New England Journal of Medicine. This is a sub-analysis of that data, which basically broke the patients out into those with target joints at baseline versus those without target joints at baseline. Presumably, those with target joints at baseline have worse joint disease and probably wouldn't necessarily respond as well, at least initially, versus those without target joints at baseline, healthier joints to start with, that should have lower bleeding rates. And essentially, what was found in the study is that concizumab was very effective at preventing bleeding for both groups. The group with previous target joints or group with target joints at baseline and those without target joints at baseline. Those with target joints at baseline did have somewhat higher annualized bleeding rates, which is not surprising, than those without target joints at baseline, because it's essentially selecting for patients with worse joint disease. But the bleed rates for those patients were still really quite low. And moving forward in time, it'll be interesting to continue to see this analysis as patients stay on concizumab, because target joints take some time to resolve. The inflammation in those joints takes time, meaning months to even some years to resolve. And so it is possible that at some point in the future, if this analysis continues to be done, that this difference between a somewhat higher bleed rate for those with target joints at baseline and those with lower target joints at baseline will become more muted and perhaps even at some point become equal. The next study is by Davide Mattino. It is called Descriptive Characterization of Bleeding Events in Participants with Severe Hemophilia A or B without inhibitors receiving prophylactic marstacimab treatment. So marstacimab is another tissue factor pathway inhibitor, similar to concizumab that I just described before. Very similar mechanism of action. Marstacimab is in fact now approved in the United States for patients with hemophilia A or B without inhibitors who are older than 12 and more than 35 kilograms. This was a study looking at detailed bleed data from the main phase 3 trial, which is called BASIS. And what Professor Mattino presented was a whole variety of different types of bleeding events, and looking at the bleeds between time periods. So the first 6 months on the main phase of marstacimab versus the second 6 months, treated bleeds versus untreated bleeds, joint bleeds, spontaneous bleeds, etc. I think the main takeaway here is that with marstacimab, the bleeding rates do seem to be a bit higher than the other medications. And that spanned across all the different types of bleeds, whether we looked at joint bleeds versus non-joint bleeds, treated bleeds versus non-treated bleeds, spontaneous bleeds versus traumatic bleeds. I think one unfortunate thing about this presentation is that the annualized bleeding rate, which is typically how we would present data like this, was not offered in the presentation. And so what we know is from the same presentation a year ago that had earlier data that the annualized bleeding rate was about 5.5 for marstacimab, but they did not show us what the bleeding rate was for this further dive into the study, which took us into like 1 year on the active treatment phase. So it was a little disappointing that we didn't get to see the annualized bleeding rate. Sitting in the audience and looking at it, it was hard as the slides were going by to calculate it, but it does seem like the bleeding rates in general and the different type of bleeds, as I mentioned earlier, with marstacimab are a bit higher than we've seen for other medications. Now, it's difficult to look at different patient populations. I mean, it's not necessarily the best thing to do to compare studies this way, but I think that was my sort of take on it, is that there were relatively higher bleeding rates compared to some of the other medications. Moving on to another drug called fitusiran. So the first presentation on fitusiran was by Steve Pipe. It was called Reduced Doses of Factor Concentrates and Bypassing Agents to Treat Breakthrough Bleeds in Patients with Hemophilia A and B on fitusiran antithrombin-based dosing regimen, which is called the Atlas OLE study, OLE meaning open label extension. It'll take way too long to get into all the previous history of fitusiran, but suffice it to say that right now there's dosing that is targeting a specific antithrombin level between 15 and 35%. So fitusiran lowers antithrombin levels, that's its mechanism of action. And in the open label extension study, we're targeting levels of antithrombin between 15 and 35%. What this analysis looked at was when bleeds did happen, how were they managed and how quickly were they controlled? So when you're on fitusiran, there's a specific bleed management guideline that uses much lower doses of factor 8 to treat bleeds or factor 9 to treat bleeds for hemophilia B, or for patients with inhibitors, lower doses of factor 7A and lower doses of FIBA. So essentially the bleed management, if you're on fitusiran, is to use whichever medication is most appropriate, whether you have hemophilia A or B, with or without inhibitors, but to use substantially lower doses than is typically used, or maybe not substantially, but much lower, typically half to quarter doses. And those bleed management guideline doses have been published in the multiple phase 3 trials that have already been published in the literature. And what Dr. Pipe showed in this study is that when bleeds did occur in patients on this trial, this extension trial with fitusiran, and again, these are patients with hemophilia A and B with and without inhibitors, that far less factor was needed. So fewer doses, less of a duration of treatment. So instead of sometimes 3 days or 4 days, it might be only 1 or 2 days. And also much lower doses because the bleed management guidelines dictate that. So essentially the takeaway from this this oral presentation is that when patients on fitusiran bleed, they need less factor to resolve their bleed. They need shorter treatment durations to resolve their bleed, and overall use a lot less product. So it's much more cost effective to manage bleeds when they do happen for those patients on fitusiran. And then the last one we'll talk about is from Dr. Sibga Zahir. It's called Assessment of the Combined Effects of Emicizumab and Fitusiran with an in vitro spiking of simulated fitusiran using antithrombin antibody into plasma from hemophilia A patients on emicizumab. And I should say, full disclosure, I'm the senior author on this paper or this abstract, and Dr. Zahir is my mentee. So you can take what I say with a grain of salt that way. But what this study aimed to look at, this was basically a laboratory study aiming to look at what is the combined effects of emicizumab and fitusiran. And the idea here is that emicizumab is currently licensed. At some point, perhaps next year, fitusiran will be licensed. And if patients want to switch from emicizumab to fitusiran, we need at least some baseline data to figure out how to do that. And that's because emicizumab has a very long half-life. So when you stop it, it takes months before it's completely out of your circulation as levels drop slowly. Furthermore, when you first dose fitusiran, it takes about a month for the onset of the antithrombin lowering of fitusiran. So with those two the long half-life of emicizumab and the slow onset of fitusiran, how is one to figure out this switching process? Now, the first thing I'll say is there is a clinical trial that is going on right now, enrolling patients switching from emicizumab to fitusiran, and really that's what's going to give us, the safety data But this study was aimed to provide some information to inform the trial. And what was shown was that as long as antithrombin levels are above the therapeutic range for fitusiran, so above 35%, that there wasn't an excessive amount of thrombin generation in patients on emicizumab. So this trial took blood from patients currently receiving emicizumab. So the emicizumab levels, if you will, are in vivo, while the fitusiran antithrombin lowering was in vitro. That was through spiking experiments of an antithrombin antibody. Once you get into the therapeutic range for fitusiran, 15 to 35%, if you are still having emicizumab levels that are therapeutic, that's when the thrombin generation started to get really high. And basically, the conclusion is that if you're on emicizumab and you have a level that is the expected therapeutic level, that is too high a level for which to have antithrombin lowering. And so therefore, when emicizumab is going to be switched over to fitusiran, there has to be a lag. Now, whether that lag needs to be a month or 2 months remains to be determined. And that lag allows for the emicizumab levels to drop while the fitusiran is slowly dropping the antithrombin levels. So we never get into a situation where both drugs are essentially in their therapeutic range, because that's what results in excessive thrombin generation. So with that, I will stop. I will thank you again for joining us for Clinical Clips in Hemophilia, Cutting Edge Advances, presented at ASH 2024. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, or ACPE credit, and to access downloadable slides, as well as other topic segments and case scenarios. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.